Was- Hi, everyone. Thanks so much for sticking with us today, sticking with me. And a big thank you to the programming committee for inviting me up to talk. Very excited to be here. We'll get right into it because I know it is the last session of the day and everybody's itching just a little bit to get going. I don't have any disclosures to make. And I want to take just a moment to talk about the objectives in the organizations. So, what I am going to spend time on today is talking about, first of all, some of the stewardship literature, some of the most impactful stewardship literature that's been published over the last 12 months. Then we're going to transition in and talk about some of the most impactful infectious diseases literature published over the last 12 months. You'll see there's always a lot of crossover between the two, and I'll try and bring out some points where I think they do cross over very nicely. Additionally, because we're trying to review a lot of things in a short period of time, I don't have time to cover everything. So if I missed your favorite study, I'm sorry. It wasn't because it wasn't good or I didn't like it or it's not important. Just trying to cover as much material as we can in a shorter period of time. You don't want me to keep you here until like 6:00. The last step before we get to some cases that I have, I am going to briefly talk about two of our guideline updates, the big ones that have occurred over the last year. I will not spend much time on them because there have already been a couple of really great talks at this summit on both of those guideline updates. So we'll just do a 30,000-foot view for a minute or two. And then lastly, like I said, what I really want to kind of just talk to you all about is applying these things to some cases that I've created. We'll actually try to work in and apply some of the actual studies to some sort of made up patient care scenarios that I've come up with. The other thing is that they will be scenarios that all pharmacy students that I would teach would hate because most of them there isn't one correct answer. But we all know those are the best kinds of questions. Let's go ahead and start right off. And I want to start off with the section talking about some of our most impactful literature in antimicrobial stewardship over the last year. The first study, I feel a little bit obligated to do this because it is such a big part of healthcare and is going to be a bigger part, is an AI-driven approach or AI-driven approaches in antimicrobial stewardship. And this was a systematic review that was published back in 2025. Now, Dr. Ernst gave an excellent talk this morning. Hopefully you all heard that. I am not even close to an expert in AI, but I believe this was an important systematic review to talk about, at least at a high level, because as he stated this morning, over the next decade, this will become, in some form or fashion, the portion of our practice. There are a couple of other things I'm going to highlight, especially in the stewardship section, themes that have been discussed throughout the summit as well, leveraging the technology that we have, even if it's not AI, but our EHR systems to help extend what we can do and make some of those functions a little bit easier. This is the higher level part of that AI. But you can see by this graphic up here, systematic review, ultimately they included 28 studies when they searched Embase and PubMed and some of the other places they went to look. And what they were really focused on is looking at studies that used AI and machine learning. And some of the key interventions that they were looking for making that are up in the upper right-hand corner there is rapidly de-escalating antibiotics and changing durations of therapy were some of the items that they were focused on. It's a little bit harder to see, but basically what I can tell you is that from the bottom right-hand corner, they found that these AI-driven approaches were really good at giving prompts to alert providers that had low MDRO risk or patients that had low MDR risk when there were instances where broader spectrum antimicrobial therapy could be decreased. Systematic review, there's sometimes only so much that we can glean from systematic reviews. That's why I didn't want to go into great detail here. But this is just a peek to what is on the horizon. And the next 5 years, certainly, we'll be seeing much more evidence like this.
Yeah. Thank you, just fitting.
to go and talk about the INSPIRE trials. I believe a lot of you might have seen the individual components of the INSPIRE trials. These were 4 cluster randomized studies evaluating antibiotic selection in non-critically ill adults with either pneumonia, UTI, abdominal infections, or skin and skin structure infections. In JAMA in 2025, there was a letter to the editor that published a lot of the aggregate results and separate results of these 4 components of the INSPIRE trial. So what was this? This is going along with our theme of trying to leverage that technology you have to make better stewardship interventions. The goal of the INSPIRE trials were to compare rates with empiric extended spectrum antibiotic days of therapy in hospitals where the providers, usually they were going to be the MDs that were writing the prescriptions via CPOE, received some built-in provenance to the EHR, recommending that they decrease or de-escalate therapy to standard spectrum therapy within our crucial first 3-day window before a lot of cultures were back. And how they achieved this, it wasn't just anybody, but this EHR was also programmed with an MDR risk score. The EHR here in these instances were flagging those patients who had a very low risk of MDR based on the score that was calculated within the MDR risk. Was less than 10%. And this was compared, those CPOE prompts, to just routine stewardship in the hospital. And again, they evaluated the empiric therapy, those first 3-day period, and then they also looked at post-empiric therapy. They were trying to determine additionally if they were reduced or if the spectrum of therapy was reduced, was that carried forward throughout the hospitalization? Here are the results. Tons of numbers there. So I really just want to call your attention, and it's really hard to see. I'm so sorry that it's so small for you guys. But if you look there on the very right-hand side of the slide, those boxes I have broken up are for pneumonia, urinary tract infections, intra-abdominal infections, and then our skin and skin structure infections. And what you can see there is there were statistically significant reductions if you look at the overall rate ratios in the physicians who were entering CPOE orders with the prompts versus routine stewardship. Even in the first one, it's about a 23% reduction in the CPOE prompt group versus routine stewardship. And we can easily get there down there to the bottom. We see with skin and skin structure infections, once again, it was about a 23% reductions, but we saw 11% reduction and around a 20% reduction in our urinary tract infection and pneumonia subcategories as well. Significant and outperformed just routine stewardship here. Now, these were also very importantly maintained for the, I'm real sorry about that. That'll wake you up in the afternoon. Those were maintained for the duration of the hospitalization for 65 to 80% of the patients as well. Overarching message for this study, again, I think, is that even if this isn't a fancy AI product that we can use, we can leverage items or functionality within some of our EHR, and it really does make an impact on narrowly antimicrobial therapy. INSPIRE trials. Now on to the next topic that I feel like is hot in the streets right now and probably always hot in the streets: prescribing for urinary tract infections. I don't want to calculate how much of a percentage of my day is spent writing notes for asymptomatic bacteria or not to prescribe antibiotics for urinary tract infections. Would probably make me pretty sad. But the other topic that's an offshoot of that is prescribing prophylactic antibiotics for some of our patients that have recurrent UTIs. And that's where the IMPRESS-U study comes in. This was done in Norway, Sweden, Poland, and the Netherlands. And effectively what we were looking at is older women who were defined as having recurrent UTIs. Those definitions were greater than or equal to 2 episodes in a 6-month period or greater than or equal to 3 urinary tract episodes in a 12-month period. And they were randomized in a 1-to-1 fashion to either receive methenamine hipurate for 6 months or placebo, so no methenamine. And then we were evaluating for the primary outcome the number of antibiotic courses for symptomatic UTIs. It calculated for their sample size, they would need 400 patients for a 25% reduction in UTI here. Now, there were two phases to this trial, which revealed something very interesting when they show you results. They had a 6-month study where the group assigned to methenamine got the methenamine, and then they followed everybody, including that group, for 6 months afterwards, after the methenamine was stopped. So that's that 6 to 12-month period or 7 to 12-month period is when no patients were getting methenamine. So look at what they found. First, just a couple of quick things on baseline characteristics. Almost no patients from Poland. The majority of the patients were from Norway, Sweden, and the Netherlands. And then what I thought beneficial to reflect the patients that we see in clinic that have these questions, the median number of UTIs in 12 months prior to randomization was about 3.5 for both groups. And there was a pretty good mix of comorbidities like diabetes, higher BMI, and then bladder dysfunction. So if you look first at our table there, what you can see is they did achieve for their primary outcome, looking at that 6 months, a 25% reduction in those prescriptions of antibiotics for symptomatic UTIs in the methenamine group. That was great. You can look up there in the table, or I'm sorry, in the bar graph in the upper right-hand side, and that's the first person over to the left, and those are the raw numbers, 87 versus 111 prescriptions. Now, what's not so great, and what we as clinicians have to keep in mind, is this completely flipped around in the second 6 months. After methenamine was stopped, there was a rebound phenomena that those patients that were in the methenamine group had a 70% likelihood of getting a prescription for an antibiotic for a UTI in the follow-up period. So we lost that. So there's the reminder that if we are using this intervention, we must be mindful and maybe even educate patients and hopefully other providers that this rebound phenomena could be possible. And it's not so much so that they were getting UTIs. That wasn't the symptomatic part. They were getting prescriptions for UTIs after the methenamine was discontinued. One of our other favorite interventions to make, I think, that is very high yield, is removing beta-lactam allergy or penicillin allergy labels from patients. Again, though, this can be another high-intensity or high-time intervention that takes a lot of our time to remove. Let's bring in the PROPEL trial now. This was published in later 2025 in the Journal of Allergen Clinical Immunology Practice. The question here was, would education and an EHR toolkit to identify low-risk penicillin allergy labeled patients facilitate inpatient penicillin allergy delabeling by pharmacists on the floor? This was a step wedge, unblinded, randomized controlled trial that was conducted at Vanderbilt University Medical Center for their 12 inpatient medical wards. They would roll this project out on one ward by 1 month and then the next ward. So they did a study to look at what the differences were, if any, between these wards during the rollouts. Education and access to an EHR-based toolkit were made accessible to inpatient pharmacists at this 1-month interval. What you can see down there in the right, in the green, that's very hard to see, but they looked at a number of things. Number one was, at discharge, was the penicillin allergy label removed from the patient's chart? Some of the key secondary outcomes that they looked at that I thought were quite interesting was, how long was this penicillin allergy label delabeling maintained? They looked at a 6-month interval and they looked at an 18-month interval to see if that persisted in the chart. They also collected data on how many patients received amoxicillin oral challenging and how that amoxicillin oral challenge was tolerated. This is just a little snippet of the Vanderbilt toolkit built into their EHR. You can see, if you look towards the right there and you look at the yellow and red and green bars, those are the assessments of what risk they were, utilizing a PENFAST score that was calculated with the data that they had that was within the EHR system. And this helped to guide those pharmacists on the floor, which were, let's say, high-yield patients that they could go after penicillin allergy delabeling for. Here are the results that are, I think, what we would hope to, and I think expect to find as well. Our primary outcome is up there at the top. Patients that were on the wards that had the EHR toolkit and education component had greater than a 2 times likelihood of that penicillin allergy being removed from the patient's chart. And if we get down at some of our key secondary outcomes, really something that stuck out to me was a received the PO challenge. It was less than 3% in both groups that actually did receive that PO amoxil challenge. And this is signaling to us, or at least me as I read the study, that you didn't even have to do that to effectively remove this penicillin allergy from the patient's chart in a lot of patients. And then what was incredibly positive is it was maintained. I think I said 6 months earlier is their first time point. I'm sorry, it was 3. Penicillin allergy remained removed from the chart for 3 months in over 97% of patients in both groups. That's excellent. And that was really maintained if we move that out to 18 months. As someone who does that, I always worry a little bit about we go through all of this work to remove it. The patient maybe isn't fully educated or forgets about it a little bit later, and it gets reintroduced into the chart at some point. Limitation here, obviously, is that it's only 18 months later, or that's how far we were looking at it. But I think this is an incredibly positive signal. I also think that this shows us that we can use our EHR systems if they have this functionality, or if we could work with our vendors or our smart folks who program these to help us with this really high yield and important intervention that antimicrobial stewards can and should make. And just to note, all patients that received the amoxicillin challenge, while they were few, they tolerated it just fine. This is my last study that I wanted to cover for our antimicrobial stewardship section, and truly this could have fit in the ID section as well. But something that we have become much better with, not people in this room, but I think other clinicians accepting, is oral therapy for bacteremia. Incredibly impactful intervention. We can save people getting PICC lines. We can get them out of the hospital sooner. We don't need to talk about all of those benefits. But I still think we have not blind spots in the data exactly, but less data than we would feel comfortable with for certain organisms. I think probably one of those organisms is Enterococcus. This was a small but pretty important study showing short courses for of therapy for uncomplicated enterococcal bacteremia. Let me back up too. Is this one was focusing more on short course versus the oral therapy. There was an oral component here, but that wasn't the focus. That should kind of be our next step. But these folks were looking at short course therapy. This was done in just hospitals in Switzerland through the longer period that was up there, and it was a retrospective study. What they defined as short course therapy was 4 to 10 days of enterococcal therapy was short, and then long duration was 11 to 15 days. You can see overall they had 331 episodes of uncomplicated bacteremia split between those groups. And then the primary composite outcome there, which were a number of things, including like bacteremia clearance and other things we would think to include there, including mortality, there was no difference at all. There were 23% in both groups in this very small study between the short course and the long course therapies. They also did some logistic regression and hazard models to try and determine what were those factors that were most effective in determining failure there in their therapy. And what you can see there, the only thing I need to draw your attention to is the very last one. Short duration of treatment was not associated with that negative outcome with regard to the primary endpoint there. Just another signal that we can get shorter with Enterococcus. Maybe it's not just a phenomenon that's 4-gram negative bacteria anymore. We already have some of this data with Staphylococci and Streptococci are coming out as well. So don't forget Enterococcus. Now let's hop over, it's not much of a hop though, and talk about some of our impactful studies in ID. The first one I know everybody's heard about, read about, was waiting for, and maybe you were a little disappointed or maybe not by the results that we found at the end. And this is the Game Changer trial. This is where we were looking at broadly cefiderocol versus the standard of care therapy for patients with gram-negative bacteremia that had obtained the bacteremia while they were in the hospital. This was an international study that was conducted in Australia, Malaysia, Singapore, Thailand, and Turkey, open label, randomized, and we had patients that were hospitalized for greater than 48 hours, and they had to have a blood culture that was positive for a gram-negative bacilli. Those folks were randomized in a 1-to-1 fashion within 48 hours to receive either the standard of care or cefiderocol therapy. And the primary outcome we were looking at here is much more of our straightforward, simple 14-day all-cause mortality. And just another note, folks in the standard of care therapy did receive up to 3 agents at the discretion of the provider. They set a non-inferiority margin here of 10%, and there was a nested superiority if the patients or if overall non-inferiority was demonstrated and the upper bound of the 95% confidence interval was less than 0. Quick baseline characteristics. The majority of these patients came from Malaysia and Thailand. We just have to keep that in mind in terms of microbial differences there. If we look down at the duration of therapy, important as well, the median was 10 days in the cefiderocol group and 13 days in the standard of care group. For our types of infections, you can see the 4 most common there that I included on the slide: urinary tract infections, intra-abdominal infections, lying-awaited infections, and then unknown. And then the last thing I want to bring up are the antimicrobial resistant organisms that were there. When you can see that we had about 13% carbapenem-resistant Enterobacterales in both groups, and then very importantly, we had about 27 total metallo-beta-lactamase producers across this trial. We're going to come back to that in just a moment. Now for the results. The primary results of the main analysis population are up over there to the left, and what you can see is probably what you would expect. There was no difference. 8% 14-day mortality in the cefiderocol group versus 7% mortality in the standard of care group. They met their criteria for non-inferiority. Very importantly, however, this is the classic have your cake and eat it too scenario. Well, they couldn't eat the cake because they did not meet their criteria for superiority based on where the lower bound of the 95% confidence interval ended up. Now, let's talk about what you're really interested in with cefiderocol. Our subpopulations of interest here, first in the upper right-hand corner, are going to be those carbapenem-resistant isolates. And here's where we started to see some not fantastic stuff. The 14-day mortality was 14% in the cefiderocol group compared to 10% in the standard of care group. That was not a great difference. I mean, it still didn't meet any kind of significance, but this is a signal that we don't like to see when this is one of those agents that we're supposed to be using or in our armamentarium to replace the standard of care therapy to treat our carbapenem-resistant isolates. Bottom left-hand corner is of even more interest and perhaps a little more alarm. If I call your attention to the very bottom left, those are our metallo-beta-lactamase producers, and 31% of the patients assigned to cefiderocol experienced 14-day mortality versus 0% in the standard of care group. Keep in mind, though, if you think back to our previous slide, this was a very small number of patients. However, I think we all know, even if we haven't done these studies, as you read the literature, it's very difficult to recruit a big study of, let's say, metallo-beta-lactamase producers. So we have to go based on this data. What does this overall show us? What do we think about this? Well, I'm not saying that cefiderocol is a bad drug, but what I'm saying is it doesn't perform in the literature the way we would like it to against these pathogens of greatest interest. And some people, and I think is an incredibly reasonable thought, to think that, like, well, what would happen if we combine cefiderocol with a really solid newer generation beta-lactamase inhibitor or one of our enhancer drugs? Maybe that's coming down the line somewhere, but it seemed like for these really bad resistant gram negatives, sulfiterol needs some help. Next, this is an oldie but a goodie. This is cefazolin. Essentially, it's cefazolin versus anti-staphylococcal penicillins for MSSA bacteremia. I can have everybody in the room close your eyes, and if you've never read this study, you could probably tell me exactly what it says in terms of results. And spoiler alert, this one is no different. However, there's a little twist on this one that I do want to talk about. This was the Cloceba trial. It was published in Lancet Infectious Diseases in later 2025, done only in France, but a multi-center study, 21 studies. It was randomized and open label, and there were some key exclusions from this population that we must be aware of. Intravascular implants before in material, patients were excluded. If they needed a duration of over 70 days, they suspected CNS involvement, or there was EGFR less than 30 were our excluded patient populations. Our primary outcome was a composite, meaning no bacteremia relapse in 90 days, clinical success at day 90, and then survival at day 90. That was the clinical primary composite that we were looking at for this study. It looked at patients that had a blood culture positive for MSSA and had received less than or equal to 72 hours of other therapy or of active therapy, and they were randomized in a 1-to-1 fashion to receive either cefazolin or cloxacillin, our ASP representative here. And they had to receive at least 7 full days of therapy, regardless of which arm they were after randomization. Non-inferiority study with the margin set at 10% and 139 patients required for each group. Just some quick baseline characteristics. I'm so sorry, I keep feeling that. I'm trying to figure out what it is that I'm doing. I'll stand further away. Just some quick baseline characteristics to talk about. I would probably say with our infections there, they weren't deeper seated infections quite as much. Endocarditis was there, but you can see smaller percentages. But the number one reasons were unknown or catheter related infections that represented the primary cause of bacteremia. And they also, if you look at the PIT scores, they were the same for each group, but they were 0 for each group, the median PIT scores. Other things there, overall duration of antibiotics, the last one I wanted to mention, mean days were about 27 days in each group. Results. I just clipped, so I'm sorry, it's like a little bit off kilter, but that's just the forest plot that I kind of clipped and pasted together for the primary outcomes and the intensity to treat and per protocol analysis. And really the important thing is, you all guessed right, that there was no significant difference, obviously, between cefazolin or our anti-staphylococcal penicillin group, and they certainly met their criteria for non-inferiority. But now here comes the kicker that I want to talk about underneath the primary outcome. They did whole genome sequencing on as many of these isolates as they could, looking for the BLA-Z allele. BLA-Z is our beta-lactamase enzyme that has been associated with the cefazolin inoculum effect in certain MSSA isolates that maybe occasionally gets us to avoid or forces us to avoid or think about using cefazolin versus an ASP in some of those infections. So they were really looking for that. And then they further did subtyping of the allele to type A, B, C, or D. What I want to show you up there is they really only presented the results here of the type A allele, the BLA-Z type A allele. And if you look at the bottom one first, no BLA-Z type A allele, you can see that our point estimate is on the side kind of like favoring cefazolin, but certainly non-significant difference there. And they met the same criteria for non-inferiority. However, if the BLA-Z type A allele was present, there was still no significant difference, but look where our point estimate was. It did jump to the other side of the line, and it was favoring or tending to favor anti-staphylococcal penicillin therapy, and at least broadly what we can say is here they did not meet the criteria for non-inferiority. You can look at the numbers, though, and incredibly important, that's 29 patients and 27 patients in the cefazolin and cloxacillin groups, respectively. So we can't make a lot of decisions based on that, certainly. But I really applaud these authors for taking this kind of tried and true concept but splicing in some of our more contemporary concern with using this type of therapy. And as you can see down there in the bottom left-hand corner, I don't even have to belabor this point. People didn't tolerate the anti-staphylococcal penicillin very well. They had higher rates of AKI, significantly higher, and they got AKI at a pretty rapid rate, like within about 7 days after it was started. Almost done. Just got two quick ones to talk about with our ID section, and then we'll go through quickly our guidelines and talk about the cases. This is one everybody was waiting on, including myself, the DOTS trial, looking at dalbavancin for Staphylococcus aureus bacteremias. This patient population, there were some key things to know from this trial if you haven't read it yet or looked into it or tried to apply it to you. All hospitalized patients, and very importantly, they have by definition complicated Staph aureus bacteremias. And so when we talk about dalbavancin dosing here, they did require, and everybody in the study got those 2 doses in the dalbavancin group, got 2 doses of dalbavancin spaced apart by 1 week. Other key things to note in the population, they had to have their blood cultures be cleared and they had to be afebrile for at least 48 hours and be included. And then they excluded CNS patients, CNS infections, left-sided infective endocarditis, and any prosthetic material if that prosthetic material was not being removed. So they were randomized in the 1-to-1 fashion to either receive dalbavancin or standard of care therapy, which a big positive of this study was limited to a single agent and was either cefazolin, and ASP, vancomycin, or daptomycin. Really quickly, for baseline characteristics here, a pretty decent reflection of patients who inject drugs. Not a lot of people, 16% and 13% in our groups. I think that's important because limits inception or time to market. This has been a population of great interest for this product and any long-acting lipoglypropeptide. And there were also a fair amount of MRSA, 34% and 32% in advancing in standard of care therapy. So many of these studies, we think like, oh, great, it worked well in MSSA. How many patients in this study got MRSA? Well, 0. Part of that was because this was done in centers in the United States and Canada, where we have more of an MRSA problem still than some of our European colleagues do. The majority of the infections came from skin and soft tissue. 54% and 51% were defined as deep-seated, and the pretty vast majority of the patients had bacteremia at the baseline before randomization that was less than 2 days. Our outcomes there. This employed our DORA outcomes, so the desirability of outcome ranking, which is a little bit more of our newfangled way of trying to look at and assess studies in patients with bacteremias, where we don't just have our binary outcomes. We have a 5-point outcome that was looking at clinical failure, infection-related complications, non-fatal serious adverse events leading to discontinuation, and then death. What they did here is then look at the probability of the outcome if you were, say, randomly assigned dalbavancin. So what the authors wanted is if that number, that probability was above 50%, that is signal that row, if you were assigned dalbavancin, you had better than a 50-50 shot of having a better DOR outcome than if you were assigned to the standard of care therapy. That was their superiority outcome. They did not meet superiority. It was 47.7%, but you can see it there in the upper right-hand portion of that slide. Very close, and there was still a non-inferiority component to this, and it definitely met non-inferiority. You can see down there the breakdown of the DOR outcomes. You can see where it kind of split for standard of care therapy, alive with 1 event. There was more in the standard of care therapy group, but then in the dalbavancin group, there were more patients alive with 2 events or alive with 3 events, and that's what drove the difference. But those differences were only like a couple in each group. This should hopefully signal to us that dalbavancin can be an effective option for patients that have Staph aureus bacteremias, one of the bacteremias that's most common that we worry about the most. But this is adding towards the growing literature that these drugs are safe and efficacious for patients with Staph aureus bacteremia. And the last thing to talk about here is a kind of brand new thing that just came out a couple of months ago and was published in JAMA Open Network. And this was a subset of the DOTS trial. It was the DOTS PK/PD analysis that was done by Tom Lodiz and a really good group of people that do a lot of excellent PK/PD work. And what they were looking at, they got as many patients as they could in the dalbavancin group that had levels drawn. And those levels, to be included here, they had as at least one booster's plasma level. And ideally, there would be more. They wanted to get them before the dose, 10 minutes after the infusion, 6, 12, and 24 hours after. And then the more key component was the days after. They also drew levels at day 8 before the second dose, and then days 22, 42, and 70. The key question here being, are those 2 doses enough for patients with complicated deep-seated infections? And is our spacing interval 8 days or 7 days, which is what was used in this study, sufficient? The results are down there in the bottom left-hand corner, and what they found is day 22 concentration was the dichotomization. This turned out to be their key point, and then they further determined that frakes that had less than or equal to 32 micrograms per milliliter, a level of less than or equal to 32 on that day 22, had a higher chance of clinical failure, or at least not achieving the clinical efficacy at day 7. There was a significantly higher rate of achieving clinical efficacy at day 70. Either levels were above 32, which is 25% greater chance there with the numbers of achieving 70-day clinical efficacy. What does this mean? Do you need to do therapeutic drug monitoring on all your dalbavancin patients? No, I don't think so. But I think this brings into question, especially with the fact that this drug might be utilized more now because it is generic now, and TDM is not some ivory tower thing any longer for dalbavancin. There are more places, there are more ways to access TDM for this agent. So if you have somebody that you're treating endocarditis with one of these agents, might you feel better about getting that level at day 22 and looking for that 32 cut point? I mean, maybe so. Somebody a lot smarter than me recently said, with this data, PK/PD analysis included, and all of the growing literature that we all know about and that we have for using oral therapy to treat bacteremias, there's almost not a reason for anybody to get a line and go home on opioids. That's not quite true, but we can certainly see things trending in that direction. Quick spin through the updated guidelines. IDSA complicated UTI guidelines were a big update. Big things there were updated classifications, removing the automatic classified as complicated UTIs, diabetes, immunocompromised virologic abnormalities. Those are gone. We have our 4-step approach to empiric agent selection. Some good data to help us that are solidified within the guidelines of IV to PO transition, and then duration of therapy, kind of solidifying 5 to 7 days for fluoroquinolone treated patients, and then that 7 days of therapy for non-fluoroquinolones if they're being utilized, even for complicated infections like pyelonephritis. So we can confidently tell all of the urologists who love to do 10 days or 14 days that that's really not necessary. And lastly, and really quickly, because again, another great session on this, we did have the update to the 2019 CAP guidelines. This, remember, not to completely replace those. These are 4 clinical questions to supplement those. And obviously the one I think that affects the most of us in the room was that second question: should adults with CAP who have a positive test for a respiratory virus be treated with antibiotic therapy? And the guideline committee said yes. IDSA said, we're out. We're not endorsing this anymore, chiefly because of that. That's a long discussion. There's been a lot written about it, a lot said about it in the podcasts and things. And those are some of the other stances on those 4 clinical updates that they have. Okay, that's all I'll say about the guidelines, because I want to talk a little bit about evidence applied to the cases. No fancy response system, so I'll just have you raise your hand, please. This is a 70-year-old female who's referred to an IV clinic for assessment of antibiotics to prevent UTIs. She reports about 3 UTIs requiring hospitalization in the last 12 months. You consult her records and the symptoms. She typically complains of her dysuria and frequency, and she has never had a pathogen isolated. She's only been treated based upon symptoms and urinalysis results. She's inquiring about long-term Cipro or nitrofurantoin to prevent those infections. She's not tried any prophylactic measures previously. She has AFib, hypertension, heart failure with preserved ejection fraction, CKD, and diabetes. She's on amiodarone, apixaban, lisinopril, metformin, metoprolol, and empagliflozin. And there are her labs there. So just really quickly, which of the following do you think is the most appropriate course of action to take? A, no prophylaxis recommended. Show us else who would do that. E, good number there. I like that one too. Recommended prophylaxis with ciprofloxacin. Even better. I don't see any hands. That's what I like. Recommended prophylaxis with nitrofurantoin or recommended prophylaxis with methenamine. Got a few for that. Yeah, they might not need anything. Maybe if you have access to a urologist who buys into a process of a more holistic approach, maybe you could send them to them. I actually work with Dr. Troutner now at the VA, and she is running a UTI clinic where she's seeing a lot of these people, and she's recommending pelvic floor exercises and some other non-pharmacologic intervention. I just want to point out a couple of things. The patient does have a decreased creatinine clearance, but it's not below the level where we could prescribe methenamine, which some variants there, but that would certainly be less than 30. I'd be incredibly worried about Cipro in somebody with AFib, and that was on amiodarone, and we don't have any of the EKG data. Long-term fluoroquinolone is not a great idea for somebody that's 70 years old. But if you think about this the rest of the way, she did fit nicely into the IMPRESS-U trial in terms of how many UTIs she's had in the last year. She was the right age, and she had no contraindications. So you could apply IMPRESS-U here to use methenamine if you so chose. Very good. Second one, I've only got 3. 60-year-old patient who resides in a long-term care facility has a chronic Foley catheter in place and is found to be septic and transferred to the hospital. While hospitalized, the urine cultures and blood cultures are growing that I like to call an pathogen that's resistant to everything. And we have some type of a CARBA-R card or some PCR genetic testing that is revealing that this is a new deli metallo-beta-lactamase producer. Some selective white blood cell counts there. So my question is, what would you do for this patient? Would you prescribe ceftazidime, avibactam plus aztreonam? Show of hands. Would you prescribe sulfiterol? Not many takers there. Would you prescribe aztreonam, avibactam? Some folks there. Ceftolozane, tazobactam. Good. You guys are too smart. Just a really quick rundown here on why. I think you all picked up right. So this would somebody that be kind of fit into the Game Changer trial, but I would be massively concerned about only treating this patient with sulfiterol. And now, granted, we don't have susceptibilities to sulfiterol, and we don't have any other susceptibilities that are related to either aztreonam, avibactam, or ceftazidime, avibactam, aztreonam. But I think that's our safest option. I also want to bring out here for just a sec that why would you maybe use aztreonam avibactam over ceftaz AV aztreonam? And the answer there is complicated, and it has to do with the ratio of beta-lactamase inhibitor and how it was paired with aztreonam in the Imblavio product. It's also easier to administer versus trying to educate nurses on the floor to like, well, you can't hang aztreonam first and then do this drug an hour later. You can't hang this drug and then an hour later hang the aztreonam. They have to be hung together. There are great protocols for that. I'm not saying that that's wrong. There's a little bit more work with that. But I think net, especially with the prices, that's going to be somewhat cheaper for you right now, and it should still be effective. So I'm not endorsing either one of those, but just some things to think about as you're talking about purchasing. I'm right about a time, so my very last one, an easy one. A patient has confirmed MSSA endocarditis with the following labs. White blood cell count of 12,000, serum creatinine 2, AST ALT of 100 over 150. This is thinking about our Cloceba trial. What would we do for this patient? And it really is coming down to cefazolin or nafcillin. You could make a case. We don't know if this person has a Blasi. They're producing the beta lactamase inhibitor. It is a deeper seated infection, so you might have some folks say like, "Well, I just want to use the ASP." But if we go back and look, I buried a couple of pharmacy student favorite Easter eggs there, so I can mark this answer kind of wrong on a test, in that they do have some elevated AST and ALTs, and their baseline renal function isn't great. We know that is still a significant issue with our ASPs. So I would still say I would probably treat this person with cefazolin, feel okay about it, but keep a close eye on things and try to ensure that they're clearing their blood cultures as quickly as possible. The other food for thought, because they don't want to keep in longer, is what about the role of a long-acting lipoglycopeptide for this patient? Would they be somebody you would think about that at? Maybe, depending on their social situation. How is their home environment? Do they have somebody that could help them do OPAT if they needed it? Would you trust them to do PO therapy? How quickly can you get their blood cultures correct? I still believe that's a very complicated situation for patients that have endocarditis. The term is going to use long-acting lipoglycopeptides, but it's out there, and I've done it some for patients who are like, I'm going home today. I don't have anybody at home to help me, and I've seen many, many people do just fine on that. But it's a shared decision making, and you have to be comfortable with the rest in the food chain.